A very warm welcome to our next lecture in the Dr. Sampath Mohanty Memorial Lecture Series. We are very delighted to continue this series with our first lecture in the new year by Dr. Rohit Mehra. It is my privilege to have Dr. Santosh Menon, Professor and Genitourinary Pathologist from Tata Memorial Hospital, as the chairperson for today's session. And Dr. Menon will kindly chair this lecture and take the proceedings forward. Over to you, sir.
Uh, Thank you, Anandi, for that kind introduction. I would like to welcome Dr. Mehra for this lecture, and it is my privilege and pleasure and honor to introduce him. Dr. Mehra is a clinical professor of pathology at University of Michigan, and he's a member of Michigan Center for Translational Pathology. And anybody who follows geopathology very ardently would know that Dr. Mehra has worked very deeply and extensively in the field of prostate cancer, renal cancer. In fact, he has pioneered translocation associated carcinomas, and he has done in-depth work in that. And his lab, along with Dr. Arul Chinayan, has discovered the TMPRSS gene fusions in prostate, which is probably the first gene to be discussed in solid epithelial tumors. And he has also done several pioneering work, and his publications are more than 300. He has served on several platforms like the Prostate Cancer Foundation, the ISUP, the GUPS, and is currently the chair of the GUPS Education Committee. And from what I know personally from about Dr. Mehra, he likes to teach, and he likes to freely disseminate his experience to everybody, and that's why he has agreed to be part of. And we are very thankful that he has agreed to be part of this. And it's an honor to be here with you, Dr. Mehra. Over to you, Dr. Mehra.
Uh, can you hear me, Santosh?
Yes, we all can hear you. Yeah.
Okay, great. Yeah. Thank you, Dr. Menon. Thank you, Dr. Lobo. Thank you, Dr. Bedi, and your entire team for this kind invitation to speak in the prestigious Dr. Sambit Mohanty series. And Sambit has been a close friend, and I think all of us have had a deep association with him. So I think it is my this is a humbling and a gratifying experience to be here today. So thank you all for this invitation. Also I see many familiar faces and names, some friends, some colleagues, some collaborators, and even some of my past fellows who are like now eminent faculty in the audience today. So thanks to everyone for taking out time to join. Santosh, I will share my screen.
Yes, sure, please.
Okay.
Yeah, we can see your screen.
Okay, great. Yeah, Santosh, yeah, if you see anything amiss, please just
Yes, I will send you.
ping me. Yeah.
Yeah.
Okay to start, Santosh?
Yes, you can please go ahead.
Okay, thank you.
Thank you, sir.
And I also want to thanks Medical Education Unit India, actually, with which I've had both a direct and indirect association in several ways over the years, and I think which has done a pioneering work in promoting health, medicine, pathology, oncology, and translational education all over the planet, actually. So I think I'm thankful for that association as well. So the topic I was assigned today by the organization committee is molecular pathology of renal tumors with biomarker updates. So all of us are well aware of the intense morphologic diversity in between different renal tumors, and these are all WHO attested renal cell carcinoma subtypes, and we can see how different these look under the microscope. These are all renal cell carcinomas, but they have no morphologic, molecular, translational, or clinical resemblance to each other. These are all very distinct and diverse entities.
Just a second. I think some of them are not. Hello. Kindly, everybody, please mute yourself. Let the speaker be only on a speaker. I think some of the people. Miss Alekhya, I think you're not muted. Please mute yourself. You
Okay,
may
thank
continue.
you, Santosh.
Yeah, you may continue.
Thanks. So all of us are pretty aware of the intense morphologic diversity in between different renal tumors, and these are all WHO tested renal cell carcinoma subtypes. And I think these have intense differences at the clinical level, pathologic level, molecular level, morphologic level. And the questions we can begin to ask are, what are we seeing under the microscope? What are the underlying mechanisms which can explain this intense heterogeneity? What are the origin of these different tumor types? These all arise in the kidney, and I think it is pretty impressive that a single organ can give rise to so many different renal tumor subtypes. Almost like more than 40 renal tumors are currently known. And how can we use this information to facilitate clinical diagnostics and research, and in the end, use it for our patients, which is the main reason all of us are here today. So I firmly believe that kidney cancer is a metabolic disease. There are at least 12 well-studied genes known to cause kidney cancer, which are listed in this box, which include VHL, MET, folliculin, FH, genes of STH complex, MITA family gene, and mTOR TSC pathway genes. Each of these genes is uniquely involved in the cell's ability to sense oxygen, iron, nutrients, or energy. And the hypothesis proposed by Otto Warburg, popularly called the Warburg effect, which states a shift from oxidative phosphorylation to aerobic glycolysis, is still considered to play a major role in kidney tumor or renal cell carcinoma pathogenesis. The same genes which are listed previously and shown here as well can be actually implicated both in a hereditary fashion or in the sporadic fashion, depending whether the mutation is germline in nature or somatic in nature. And I think these are most of the renal neoplasms which are currently we are aware of. And like I mentioned before, each of these neoplasm or renal cell carcinoma subtypes is associated with a unique genomic aberration and a genomic signature dysfunction. Then there is also the concept of molecularly defined renal cell carcinoma. Actually, if we look at all renal cell carcinoma subtypes, almost all of them have a known underlying molecular underpinning. But the reason WHO came up in 2022 with this concept, or specifically categorized are associated with these genetic aberrations, and they actually need a specific molecular assay for diagnostic confirmation. This is the reason that they have been placed actually under the molecularly defined renal cell carcinoma, which includes tumors with genomic aberrations involving the TFE3 gene, TFEB gene, ALOC, FH, STH, ALK, and SMARCB1 or INA1. And I will talk a little bit more about this in the coming slides. So whenever we have a kidney biopsy or resection, I always tell my residents and fellows, I think it's important to remember that there are processes which are not inherently intrinsic to the kidney, which can involve the kidney. For example, we can have urothelial carcinomas, melanomas, both primary and metastatic. I have seen a few primary melanomas of the kidney. Then metastases to the kidney coming from other organ systems. For example, lung is actually known to metastasize commonly to the kidney. And then lymphomas as well can involve the kidney. And these are inherently non-renal processes. But then there are inherently primary renal cortical or medullary processes which are nephronal based. And these can also involve the kidney. And these are the current distinctions we attempt to make at the clinical level as well as the pathologic level, which includes distinction in between clear cell RCC and non-clear cell RCC. There are renal tumors with syndromic annotations, and then there are also tumors which are inherently more aggressive in nature. And the reason is that the granularity between the treatment and management of clear cell and non-clear cell RCC is increasing more and more. If we look at the diagnostic algorithms and also the associated therapeutic algorithms, they actually diverge quite a bit now for patients with clear cell RCC and non-clear cell RCC. Patients with syndromic RCC tend to have surveillance as well as familial implications. And of course, the concept of precision surgery applies now very well to syndromic RCC. Dr. Ball has done a lot of work in this area. And then cytotoxic treatment might be more amenable for patients who have inherently more aggressive renal cell carcinomas. Then there are still tumors we are still unable to categorize faithfully into the known categories, and these are what are known as the RCC unclassified or not otherwise specified. And as pathologists, it is still important for us to categorize these either into low grade or high grade, because the management implications will depend on this feature, whether this RCC unclassified or not otherwise specified is called as low grade or high grade. In the same vein, there are several clinical trials now which have emerged in the non-clear cell space. This is a nice review article by Pavlos, and I think I would recommend all of you visiting to understand this concept of clear cell RCC versus non-clear cell RCC, especially the distinction in between these, tumor subtypes. I think I really like this Casey Cure website. I think I think Casey Cure does a great job of refreshing the current up-to-date clinical trials, like where they are accruing patients, what kind of disease it is it clear cell or non-clear cell, and within non-clear cell also we can see there are actually quite a lot of entities now which are being targeted through molecularly informed clinical trials. So I think please visit this resource as well when you can. This is my current understanding of the different management algorithms for patients with different renal cell carcinoma subtypes. And I think what we know now are that there is considerable granularity in terms of, does the patient have a clear cell RCC? Are there any sarcomatoid features or rhabdoid features, or what kind of non-clear cell renal cell carcinoma or what kind of non-clear cell renal cell carcinoma does the patient have, which will impact again management for patients with renal cell carcinoma. And I think this is the reason we as surgical pathologists work so hard, so we can inform our clinical colleagues of the best possible decision in terms of diagnostic categorization for renal tumors, because there are associated management implications. I think it's also important to remember that I think we need to make sure that we are following our clinical colleagues' work, because there is so much movement in the RCC space currently, especially on the clinical front, that as pathologists we can do a good job only when we keep in tune with the cutting edge advances which are happening in the renal world at the clinical level. I really like this review article on EAU. EAU guidelines are released every year, and I think this is the 2025 EAU RCC update, and I think I would highly recommend visiting this review article as well. I mean, of course, I will not be able to cover it today, but I hope all of you can visit. I will point out one salient feature, that in terms of treatment of locally advanced renal cell carcinoma, now there is the concept of giving adjuvant pembro to patients with clear cell renal cell carcinoma, as well as some non-clear cell RCC as well. And who are the patients who qualify for this adjuvant pembro? I think that is based on their recurrence risk, and this recurrence risk we follow is defined as shown in the Keynote 564 trial, which defines intermediate high risk patients, and these are the patients who are eligible for adjuvant therapy with pembro. And like we can see here, these are all the pathology-driven criteria. So I think pathologist's role is very important in determination what kind of treatment patients get. For example, pembro is currently advocated for patients who have RCC, which is PT2, grade 4 or sarcomatoid, any PT3 or any PT4, and any patients who have locally advanced, locally metastatic or distant metastatic disease as well. So I think this just talks about the importance of the role of surgical pathologists in the kidney cancer world on a daily basis. So human kidney, as we know, is anatomically and histologically a very complex parenchyma, and each kidney has about 900,000 nephrons, and each nephron constitutes the anatomic, histologic, functional, and physiologic unit of each kidney. And then there are specific cells along the epithelial lining of nephron, which determine the unique physiologic functionality. And like any cell in the human body, these cells also carry a potential for neoplastic transformation. We have indeed done cell of origin predictions for different renal cell carcinoma subtypes. We published this study a few years back, and this study is based on single cell sequencing, where we are able to perform putative cell of origin predictions for different renal cell carcinoma subtypes. So the way to read this figure from this paper is that these are radar plots, and these are different cell types which are listed along the outside of the radar plot, going from the proximal nephron cells, which include PT A cell, B cell, C cell of the proximal nephron, then cells emanating from loop of Henle, and then the distal nephron cells, which include the intercalated cells and principal cells. And we can see that tumors like clear cell RCC, papillary RCC, and MITF RCC originate from this uncommon PTB cell. So the way to read this radar plot again is these are the cells lining the nephron, and this spoke, this length and direction of the spoke indicates the probable cell of origin. So like I mentioned, clear cell RCC, papillary RCC, and majority of MITF RCC originate from this uncommon PTB cell. And chromophobe renal cell carcinoma, like we know, originates from the intercalated cell. So I think this study has brought a frame shift change in our understanding of kidney cancer in terms of their pathogenesis and genesis. We are also able to also nominate now cancer-specific biomarkers and lineage-specific biomarkers for different renal tumor subtypes, utilizing this specific strategy. I've also had discussion with professors in anatomy on this topic, and I think professors in anatomy in this. I've also had discussion with some professors in anatomy, both in North India as well as here in Michigan on this topic, and I think they find this a revelation that we are able to now do this kind of analysis. So beginning with clear cell renal cell carcinoma, which is the commonest renal epithelial malignancy in adults, like everyone probably knows here, this tumor is diagnosed based on this racemose vascular network, which is this chicken wire kind of network we can see. It's not based on optical clarity. Optical clarity is seen only in about 60% of clear cell renal cell carcinoma. Once tumors start becoming higher grade, this optical clarity starts changing because the proteogenomic content starts changing, and hence tumors stop being clear in nature and move on more to be eosinophilic in nature. VHL is a tumor suppressor gene at 3p25, which is implicated in high majority of clear cell renal cell carcinoma, and it can be silenced via multiple mechanisms. So once VHL is lost, there is stabilization of the HIF proteins, which in turn leads to overexpression of various HIF target genes. And overexpression of these HIF target genes leads to enhanced metabolic phenomena like angiogenesis, glycolysis, and apoptosis. And actually, these are effects we can see under the microscope. For example, enhanced angiogenesis is seen as this racemose vascular network. We don't really know why this enhanced angiogenesis itself comes up or becomes apparent as this racemose vascular network, but this is a reflection of the direct dysfunction of the VHL pathway. Increase in glycolysis and apoptosis leads to heightened glycogen and lipid content in these cells. And actually, these are chemicals or metabolites which get washed away when we do tissue preparation. And that is the reason for the low-grade clear cell RCC to have this optical clarity look. When tumors become higher grade, or when clear cell RCC becomes higher grade in nature, actually the proteogenomic content of these cells changes, and hence they become more eosinophilic in nature. Overexpression of HIF target genes also leads to overexpression of downstream biomarkers like CA9, which, like you know, is carbonic anhydrase 9, a membranous ligand, and we use this in our surgical pathology practice on a daily basis to resolve challenging renal tumor cases. Let us review this example of a high-grade renal cell carcinoma with papillary features. I hope all of you can appreciate, even at the low power, this tumor has an intense papillary architecture. This is again a medium power view. We can see the papillary architecture, and we can see also these cells which have abundant clear cytoplasm. So there are several differential diagnoses one can consider for a tumor like this. And when I worked up this tumor, it was strongly positive for CA9 expression, like we can see over here. So the way to interpret CA9 is to look for brisk membranous expression. CA9 is a membranous ligand, and hence membranous expression is what it matters. If there is only a cytoplasmic blush, or if CA9 is seen only in perinecrotic areas, it is non-specific in nature. So based on the CA9 expression, I was able to diagnose this tumor as a high-grade clear cell RCC with a true papillary phenotype, which is quite uncommon for clear cell renal cell carcinoma patients. Since the tumor is so uncommon, or this kind of tumor is so uncommon, we also did molecular analysis which showed 3p loss or 3p deletion for this tumor, indicating a or confirming a clear cell RCC phenotype. So while we have utilized CA9 diagnostically, our clinical colleagues have also really utilized and banked upon a dysfunctional VHL pathway, because once VHL pathway becomes dysfunctional, there is overexpression of downstream biomarkers or molecular entities like VEGF and PDGF. And like you know, the entire tyrosine kinase inhibitor therapy is based on dysregulation of the VEGF and the PDGF pathway. And also, I hope you have been following the remarkable belzutifan story. In 2021, belzutifan was approved for patients or adult patients who have several tumors associated with VHL disease. And I think I would highly recommend visiting this NEJM paper, which showed us that belzutifan will lead to a reduction of different tumor subtypes, not only renal tumors, but also other tumors associated with VHL syndrome, like, for example, hemangioblastomas and pancreatic tumors. And belzutifan can lead to a remarkable reduction of the tumor size. Currently, belzutifan is also approved for treatment of patients with advanced renal cell carcinoma or advanced clear cell renal cell carcinoma, which are refractory to other main line therapeutic regimens. And just so everyone knows, I'm sure everyone knows, belzutifan is a HIF inhibitor, and this is like an oral drug. So I think this is just like a remarkable development in the treatment of patients with renal cell carcinoma. Let us review another high-grade clear cell renal cell carcinoma. This one shows abundant eosinophilic cytoplasm. I think we can see the eccentric nature of the cytoplasm. There are large nuclei with anaplasia, prominent nucleoli, slightly coarse chromatin, and then we also have these globular inclusions which are placed within these cells. And of course, this is high-grade clear cell RCC with rhabdoid features, which is known to be a poor prognosticator for patients with clear cell renal cell carcinoma or other renal cell carcinoma subtypes. But why is this morphology so associated? Why is this morphology associated with a poor prognosis? So I always tell residents and fellows and trainees that it's very important to ask why to what we are doing and what we are seeing, and why are there these clinical correlations. This is the corresponding BAP1 stain over here. We can see that BAP1 expression is lost within the neoplastic cells, with retained expression within the background stromal inflammatory and endothelial cells, which counts as internal positive control for this marker. So now we have a unique morphology with a unique molecular correlate. And I think based on work in TCGA, we have seen that patients who have BAP1 mutations tend to have a poor survival, or a way poor survival, than patients who have wild type BAP1. And this has been shown in several multivariate studies also now as well. So I think I find it fascinating that there is a unique morphology which is known to be associated with a poor prognosis. And then we have an underlying molecular genomic aberration, which is independently shown to be associated with poor survival. So I think this is a nice example of a clinical morphologic and underlying genomic or translational correlate. Let us review another renal cell carcinoma. Even at low power, we can see there is a high-grade spindle cell phenotype, and there is osteoid and bone formation within this tumor. This is obviously a high-grade sarcomatoid malignancy. And when I worked up this tumor, it was positive for pan-cytokeratin, PAX8, and also strong CA9 expression, like shown over here. So this is an example of high-grade clear cell RCC with sarcomatoid features. And development of sarcomatoid features is known to be a definitive poor prognosticator for patients with clear cell renal cell carcinoma. This is my current understanding of the different factors which will influence prognosis and outcome for patients with clear cell renal cell carcinoma. Of course, tumor stage is paramount. Presence of rhabdoid features, sarcomatoid features, presence of tumor necrosis, as shown by elegant work done at the Mayo Clinic, is all contributory towards the clinical outcome for patients with clear cell renal cell carcinoma. At the molecular level, what we know is that BAP1 loss, chromosome 9 and 14 losses, gain of 5q, as well as the SIMP status, or the methylation phenotype of these different renal tumors is also important. And I will share a little bit more about this in the coming slides. And then profound genomic intratumoral heterogeneity does not matter whether it's primary tumor or metastatic tumor, is now also known to be a contributor towards poor prognosis for patients with clear cell renal cell carcinoma. Moving on to the next tumor, like you know, papillary renal cell carcinoma is the second commonest renal epithelial malignancy in adults. And this is like the classic features for papillary renal cell carcinoma, where we have expanded lamina proprias with fibrovascular cores and stuffed with these histiocytes. And then we have a covoidal to low columnar
बिल्कुल
basophil.
बेकार है.
Hello, Mrs. Dr. Kavna, please mute yourself.
And then we have this covoidal to low columnar. Then we have a covoidal to low columnar lining, and this is like telltale for papillary renal cell carcinoma. If you do geopathology on a daily basis, like I do, you might also have uncommonly come across these papillary renal cell carcinomas, which can have foci or low-grade spindle cell foci. And the way to distinguish this, these have this irregular jagged phenotype. I hope you can see this irregular tubular nature of this low-grade spindle cell foci. Dr. Pete Ergani from Hopkins has described these entity, but this is not a poor prognosticator. I think it's important to not overcall these as sarcomatoid change. Having said that, we do have uncommonly high-grade papillary renal cell carcinoma with sarcomatoid features. I think this tumor was deceptive because while there is an obviously a papillary renal cell carcinoma, I hope you can appreciate in the background there is actually a high-grade spindle cell proliferation, and which was more evident in other areas. This is part of the same tumor, which was like only a minority. The majority of this tumor was comprised of these areas. So this is an example of a high-grade papillary renal cell carcinoma with sarcomatoid features, which is very different from these low-grade spindle cell foci we can see in such tumors. I briefly brought up concept of DNA methylation in kidney cancer. So the majority of this work has been done by the TCGA, and there's this concept of increased somatic DNA hypermethylation in all different renal cell carcinoma subtypes. And if we look at these pie charts, these colored segments actually show these renal cell carcinomas which are hypermethylated at the genomic level. And the reason this is very important is all of these hypermethylated renal tumors, irrespective of the subtype, like shown in this KM curve, tend to have a poor prognosis. It is very well established that increased DNA hypermethylation is now known to be correlated with poor patient survival. However, I would like to point out to this red small segment, which is a specific subset of papillary renal cell carcinoma or RCC with papillary features, which are characterized by a specific genome-wide CpG island methylator phenotype. And these are the patients we know as SIMP papillary RCC. And like we can see in this KM curve, patients with SIMP RCC with papillary features have the poorest survival amongst all renal cell carcinoma subtypes. And it is important for us to be able to, in advance, diagnose or detect these patients. And we really need a biomarker in this space. And our laboratory has been working on these cases, and we have nominated a biomarker in this space, and that manuscript is currently under preparation. So I hope we'll be able to release that in the public domain in this year at some point. So if we think about the phenomena of SIMP RCC, actually, if we talk about FH deficient RCC or HLRCC associated renal cell carcinoma and the STH deficient RCC, actually, the reason a lot of these HLRCC RCC or STH RCC tend to have a poor prognosis is because they fall under the SIMP RCC phenotype. And let us review this different renal cell carcinoma, which can also show focally papillary features. But like seen in this image, there is a background, mucinous or myxoid background, and then we have these epithelioid cells which are arranged in a tubular network, and also there is a low-grade spindle cell phenotype. And like the name suggests, this is a mucinous tubular and spindle cell carcinoma of the kidney. This is a very unique tumor with a unique morphologic appearance under the microscope. And we have always wondered, why does this tumor look so different and distinct for other renal tumor subtypes? So our group at University of Michigan and also Dr. Reuter and colleagues at MSKCC have done intense genomic interrogation of these tumors, and we have found there is biallelic alteration and dysregulation of hippo pathway in the majority of these tumors. Also, like we can see in this pictogram, there is a loss of chromosome 1, 4, 6, 8, 9, 13, 14, 15, and 22 in the majority of mucinous tubular spindle cell carcinoma renal tumors. And this specific signature or this specific chromosomal signature is actually highly specific for a diagnosis of MTSSC of the kidney. So for those who are not familiar with Hippo pathway, actually this is a pathway which has been recently worked upon, and this pathway is co-regulated by determinants of cell polarity and junctions, as well as contributes to mechanical stiffness and cell geometry. So Hippo pathway is implicated currently in the majority of, or Hippo pathway dysfunction is currently implicated in the majority of MTSSC of the kidney, and also about 20 or 25% of sarcomatoid renal cell carcinoma. And I find it interesting that a pathway which influences cell shape and cell geometry, once this pathway becomes dysfunctional, it leads to actually a spindle cell phenotype. And I think more work needs to be done in this arena. So I hope that the residents and fellows and trainees on this call, at least one of them can pick up this interrogation and enlighten us what are the underlying mechanisms behind this correlation. Like I have shown papillary renal cell carcinoma with a low-grade spindle cell phenotype, like also seen in this image. And uncommonly, papillary renal cell carcinomas can also have intratumoral mucin, which can be intracellular or extracellular within the background stroma. MTSCC cases, like we can see here, also tend to have a tubular phenotype. And one of the morphologic features can be helpful is the papillary RCC, like Dr. Tiku always says, papillary RCC tend to have an irregular or jagged phenotype, whereas MTSCC tend to have a smooth tubular phenotype. But still, there will be cases we won't be able to distinguish faithfully at the morphologic level, because we can also have mucin pure MTSSC, and we can also have high-grade MTSSC, which can be tough to diagnose. And the way to distinguish them is to do copy number analysis or copy number variation analysis or CNV analysis, which will show 717 gain in papillary RCC and will show signature multiple chromosomal losses in MTSSC. So CNV or copy number variation analysis can be very helpful in distinguishing these two different renal tumor subtypes when needed. Let us review a different renal cell carcinoma. Here we can see the background renal parenchyma. And again, we can say here this is a renal cell carcinoma with papillary architecture or papillary features. Even at low power, we can see the psammomatous calcifications. At high power view, again, we can see the calcs here. This tumor has a papillary phenotype, abundant eosinophilic cytoplasm, nuclear pseudostratification, high degree of nuclear anaplasia. This is actually a great fit for the erstwhile type 2 papillary renal cell carcinoma, but there is an inherent problem with the nomenclature. For example, when we worked up this tumor, it was positive for TFE3 gene rearrangement. And this is an example actually of a TFE3 altered renal cell carcinoma. And this is actually one of the reasons that we have abandoned the erstwhile type 2 papillary RCC morphology or nomenclature. The reason being that high majority of these tumors were actually not even papillary renal cell carcinoma. This is my current understanding of MITF family altered renal cell carcinoma, which includes tumors with TFE3 translocations, tumors with TFE-B translocations, and then tumors with TFE-B locus or 6p21 based amplification. And fluorescent in situ hybridization or FISH is currently considered to be the gold standard for diagnosing and distinguishing these three different renal cell carcinoma subtypes under the MITF family altered RCC tumors. Now, I will spend a few minutes on the TFE-B amplified renal cell carcinoma. The reason being that this has been more recently described, and second thing is these tumors invariably are high grade in nature, and almost 50% of these can be 40 to 50% of these can be metastatic in nature and even show early metastases. So I think we cannot afford to miss this at the surgical pathologic level. These tumors are also diagnosed in higher age range than the TFE3 rearranged or TFE-B rearranged tumors. At the FISH level, these tumors are defined by presence of 10 or more copies of the TFE-B locus in at least 10% of the cells. So let us review a few examples of TFE-B amplified RCC. So this is an example of a high-grade RCC which shows again a nested phenotype. There is a racemose vascular network, and it is pleomorphic in nature. And we can see there are actually quite a few intranuclear inclusions within this tumor, which is unusual for high-grade clear cell renal cell carcinoma. I mean, tumors don't read books, but still, based on the trends we can see or what we have seen in literature, high-grade RCC will not commonly have so many intranuclear inclusions. Also, this tumor is inherently a little bit more pleomorphic at the cellular level than a high-grade clear cell RCC. So while this tumor actually looks like a high-grade clear cell RCC, it is not. And based on the features I mentioned, which is profound cellular heterogeneity as well as intranuclear inclusions, I worked up this tumor further, and actually this turned out to be a TFE-B amplified renal cell carcinoma. This is the most classic look for TFE-B amplified renal cell carcinoma, where renal tumors have a high-grade eosinophilic and papillary features like seen in this image. And we can also see this nuclear array or linear array of nuclei, which is pushed away from the basement membrane. We do not know why these nuclei are pushed away from basement membrane in these tumors, but that is another topic hopefully our residents and fellows and trainees can pick up and work on. Having said that, this look is quite classic for TFE-B amplified renal cell carcinoma. It can also be seen in other MITF RCC uncommonly, and also very uncommonly in some other different renal tumor subtypes. So obviously, interrogation has to be made in the correct clinical pathologic context. This patient's tumor actually was diagnosed as chromophobe renal cell carcinoma at an outside facility, and then someone accidentally did a melanome, which was strongly positive in this tumor. And then this case was referred to us. And when I reviewed this case, there were chromophobe-like areas, but again, there was way more heterogeneity than we would see in a chromophobe renal cell carcinoma. And when I worked up this tumor further, it was positive for TFE-B amplification. So I think we should remember that TFE-B amplified renal cell carcinoma can show diverse looks and forms and morphologic appearances under the microscope. For example, this is a tumor which is an alveolar phenotype with chromophobe RCC-like features. Like I mentioned, FISH for TFE3 and TFE-B gene aberrations is currently utilized for diagnostics for these tumors, and these FISH for these aberrations is currently offered at most tertiary centers currently all over the planet. We have currently performed more than 1,000.
Dr. Vinod Kumar, kindly mute yourself.
We have currently performed more than 1,000 clinical FISH assays on more than 500 renal tumors, which were suspicious at the morphologic or biomarker level for MITF abnormality. And we have published our experience a couple of years back now on the first 801 clinical FISH assay results. Currently, I think our number is almost more than 1,100 or 1,200. I direct our GU FISH and GU esoteric asset development functionality at University of Michigan, and I think thankfully because of this and because of our consult and referral service, I'm able to see very unique renal tumors almost on a weekly or a daily basis. And if you are able to review this study, I think I've noted on the salient features. One is that TFE3 and TFE-B rearrangements are never co-detected within the same renal tumor, and that is because these are canonical gene aberrations, and I think hence won't co-happen in the same tumor, I think, by the rules and laws of molecular biology. Then very importantly, patients who have TFE-B amplification are significantly older than those with TFE3 translocation or TFE-B translocation. And also TFE-B amplification is at least 3 times as common as TFE-B translocation. And again, the reason we can't afford to miss tumors or patients who have TFE-B amplification is that majority of these tumors tend to have a worse outcome. We have also performed RNA sequencing on these tumors, and we have found this gene called TRIM63 to be highly overexpressed. In almost all of the TFE3 translocation cases, TFE-B translocation cases, and TFE-B amplification cases. And we have used a unique RNA in situ hybridization technology where we are able to visualize the RNA transcript directly under the microscope. For example, this is a TRIM63 RNA here, and each of these brown granular dot here represents the TRIM63 RNA transcript. Of course, the signal is amplified, and TRIM63 by RNA is seen to be overexpressed in all of these different mid-type renal cell carcinoma subtypes. This is the power and magic of RNA in situ hybridization technology, that we are able to visualize the gene product directly. We are able to visualize the gene product directly under the microscope. We have also recently reviewed cases where there was a morphologic impression of mid-type RCC. And then we did biomarker workup, and these cases were positive for TRIM63 expression, like seen by this RNA image. But when we did FISH for TFE3 and TFE-B gene aberrations, FISH was negative in these tumors. So we ended up sequencing a cohort of such tumors, and we found that 70% of such tumors, as we showed in this very recent publication, which was led by Rahul and Mindy, and also by other colleagues. At our institution and partnering institutions, we were able to actually show that about 70% of such tumors, which appear as mid-type RCC under the microscope, are TRIM63 positive and are FISH negative. They actually do house structural mid-type gene-based aberrations. For example, this particular tumor had a non-TFE3 based fusion, and like you may know, this is a intrachromosomal inversion leading to fusion. So I think we find this biomarker very helpful in our clinical practice, and we have had this biomarker almost for more than 2 years now. So when to consider a possibility of mid-type RCC, I think morphology is very important. Older age does not rule out mid-type RCC. The highest age patient I have seen so far is about 88 years who had a diagnosis of mid-type RCC. Please do not use pan-cytokeratin ISC as a screening tool. While pan-cytokeratin and other keratins will be underexpressed in mid-type RCC, almost 50% of, or more than that, of mid-type RCC will show focal to patchy expression and even diffuse expression of mid-type RCC. And I see sometimes experienced pathologists using pan-cytokeratin ISC as a screening tool, but I think this is a major pitfall in this space. And like I mentioned, FISH shows a high degree of sensitivity and specificity, and it is important to consider mid-type RCC in the differential diagnosis of any unusual, difficult to classify renal tumor. This is my current diagnostic approach towards mid-type RCC. If I have an appropriate morphology within renal tumor for mid-type RCC, or if there's a difficult to classify renal tumor, and of course, we have to rule out possibility of other tumor subtypes for a difficult to classify renal tumors. And if TRIM63 is positive by RNA in such a tumor, then I resort to FISH testing, which will, in high majority of instances, will show mid-type RCC. And when FISH is negative, then we can resort to next generation sequencing based approach, and this is generally a collective decision made in communication with the patient's urologic oncologist or medical oncologist. Moving on to one of the, or perhaps the third segment of my talk, which is of the oncocytic tumors of kidney. This is my current approach to low-grade renal oncocytic tumors of the kidney, which of course obviously needs about 2 hours or more of discussion. So we will not be able to go into that, but I will share some interesting or exciting tumor updates, especially in terms of clinical pathological and translational features. These are the classic features for renal oncocytoma: chromophobe RCC, eosinophilic pattern of chromophobe, and I think I'm sure you're all very familiar with these tumors, which we don't uncommonly see on a daily basis. Chromophobe RCC is diagnosed by this plate or trabecular-like architecture, thick cellular membranes, perinuclear halos, and then nuclear membrane wrinkling, and these are telltale features for chromophobe RCC. Currently, grading of chromophobe RCC is not recommended, and the morphologic behaviors associated with poor outcome, or the morphologic features associated with poor outcome, include tumor stage, necrosis, sarcomatoid features, as well as lymphovascular or microvessel involvement by tumor. Like I mentioned before, sarcomatoid features in any renal tumor portends a worse prognosis. Here, this is an example of islands of residual chromophobe RCC associated with a sarcomatoid phenotype. These are here again like some residual islands of chromophobe RCC with this intense intermingling with a high-grade sarcomatoid phenotype and high degree of nuclear anaplasia. I think this sarcomatoid change within chromophobe RCC does need to be distinguished from the random degenerative atypia we can see actually not uncommonly. We can see not uncommonly within renal tumors. And we do not know why this degenerative atypia is so uncommon in these oncocytic renal tumors. I think we are still trying to figure out the question like, why does it happen? But this needs to be distinguished because this has no outcome association compared to true sarcomatoid features. And when in doubt, MIB1 staining or Ki67 based proliferation activity can be helpful in distinguishing these two entities. The molecular features associated with poor prognosis in chromophobe RCC patients include genomic aberrations involving TP53, PTEN, and CDKN2A, and also the concept of DNA, hypermethylation, which can be again, like I mentioned, which can be helpful towards indicating a poor prognosis for these patients. Let us review this renal tumor biopsy from a 63-year-old female patient who had about a 3-centimeter tumor. I came across this case several years back, and we can see even at this intermediate power view, we can see there are areas of tumor which perhaps resemble a renal oncocytoma. There is a relative nuclear uniformity, eosinophilic features, but interestingly, there is an abrupt juxtaposition to these cells which have cytoplasmic clarity. Actually, there are quite a few once we start viewing this. So this tumors has at the naked eye level or the microscopic levels, perhaps a resemblance to some areas resembling an oncocytoma, and then the cytoplasmic clarity is perhaps reminiscent of some chromophobe RCC areas, but I don't really see great nuclear irregularities in this tumor in any cell, but there is some cytoplasmic clarity. And these tumors historically have been called as hybrid oncocytic tumors because in the past it was thought this tumor is composed of hybrid features of oncocytoma and of chromophobe renal cell carcinoma. But if we look at the corresponding immunophenotype, PAX8 is uniformly positive, CK7 shows patchy expression. But if we see CD117 has a checkered expression, meaning that if this tumor was truly composed of oncocytoma and chromophobe RCC, which are both known to be positive for CD117, if this tumor was truly composed of a mixture of chromophobe RCC and oncocytoma, the entire tumor would be uniformly positive for CD117, but instead 117 is expressed in a checkered fashion, meaning that there are islands or groups of cells which are positive for CD117. But if we see in the background, actually there are quite a few, again, islands and groups of cells in again a checkered fashion which are negative for CD117. Our eyes tend to naturally gravitate towards these cells which are positive expression, but that's a visual aberration. But I think there are actually quite a few, almost 40 to 50% of cells which are negative for CD117. And I've always thought about like, what are these cells? Over the years, I've thought about like, what are these cells which don't have CD117 expression? We over the last few years, in this study led by my colleague Mindy Wang, over the last few years, we have now performed RNA sequencing on these hybrid oncocytic tumors. And what we found out that while the first population of cells is CD117, there is a second population of cells which is actually labeled by this marker called L1CAM, which labels principal cells and few other cell types in the kidney. So actually this tumor is hybrid, not because if it has areas of oncocytoma and chromophobe RCC. It is hybrid because this tumor is hybrid because it has dual cellular lineage areas. One cellular population is marked by CD117, which is also seen in intercalated cell of the kidney, and the other cellular population is marked by L1CAM, which is seen in predominantly in principal cell as well as a few other cell types of the kidney. So this is a very unique neoplasm where there is a dual cellular lineage. Both the populations are still clonal in Nature, though. So I think this is a very interesting neoplasm. So please visit this study when you can. We have also seen L1-CAM expression in this recently described entity, which is called low-grade oncocytic tumor, or another proposed name is principal cell adenoma of the kidney for this tumor. These tumors tend to have dysfunction of the mTOR pathway with mTOR activating mutations. And at the microscopic level, these tumors show a nested appearance, eosinophilic features, subtle perinuclear halos. A lot of these tumors were called eosinophilic pattern of chromophobe or perhaps oncocytoma in the past. But these tumors are L1-CAM positive, CK7 positive, CD117 negative, and these are known as low-grade oncocytic tumors of the kidney. So, so we can have an intense oncocytic neoplastic output from the distal nephron, where we have cells of distal nephron giving rise to all these different renal tumor subtypes, which include but are not limited to oncocytoma, HOT, chromophobe RCC, eosinophilic pattern of chromophobe, LOT, as well as a few others. But the cell of origin is likely contributing to the morphologic similarity in between these different tumors. But these are not progression events at genomic level. Actually, each of these tumor has a very unique genomic aberration expression signature. The copy number changes or variations are different in between these tumors, and the metabolic insult seen in these tumors is also different. But probably some degree of similarities arising from the fact that these cells have a relatively similar segment of nephronal origin, but very importantly, these tumors are not progression events in between one another. This is my current understanding of the majority of renal tumors with eosinophilic or oncocytic features, including the morphologic features. We can see what are the possible or repetitive cell of origin, what is the biomarker profile, and the underlying genomic aberrations. I hope all of you will find this helpful. No study or no talk can be complete today without at least briefly mentioning the mTOR-TSC family of renal tumors. This is an evolving concept as I speak, and mTOR-TSC family dysfunction can get implicated in kidney cancer both at the hereditary level or at the sporadic level. And these are currently the tumors where we think mTOR-TSC family tends to play a very important role, which includes eosinophilic pattern of chromophobe, eosinophilic vacuolated tumor, RCC with FMS, low-grade oncocytic tumor. And also this particular tumor, which can show a cystic phenotype, has solid areas, and then these large cells where several of the cells show basophilic stippling. And this is an example of a eosinophilic solid and cystic renal cell carcinoma of the kidney. We and other groups have done extensive work on this tumor, and what we have found out that these tumors, which in the sporadic space are known as sCRCC, and which is like the majority of these tumors, and in the hereditary space, these are known as TSC, RCC. I think these are about 90%, and these are about 10% within this domain itself. But what we and others have shown that both of these tumors have aberrations within TSC1 and TSC2 genes, and depending whether the biallelic loss is germline or hereditary in nature, or whether the biallelic loss is somatic in nature, these tumors are called TSC RCC and sCRCC. And now, because of this work as well as other work done by colleagues in different institutions, sCRCC is now included in the 2022 WHO renal tumor classification. GPNMB has emerged as an important biomarker in the renal tumor space now. I think while it is very sensitive for the mTOR-TSC family renal tumors, it can, like shown over here, this is GPNMB in sCRCC, EVT, and LOT. But we have to remember that this biomarker can also be expressed in other renal tumor subtypes, especially MITF-RCC, then angiomyolipomas, follicular-mutated renal cell tumors. So I think it's important to remember that these interpretations have to be made in the correct context. People talk a lot about sensitivity and specificity of different biomarkers, and also how new biomarkers are exciting and older ones, I think they diminish in importance. But I always say and think that each biomarker has to be evaluated in the correct clinical context, and each one carries its own unique value. Sambit and team actually did amazing work on eosinophilic renal tumors, and I think this is a recent article which was published by Sambit Anandi, Santosh, and colleagues all across the world. And here we can see that they actually came up with this nice algorithm which can help surgical pathologists on a daily basis. So please visit this nice article when you can. I'll briefly spend maybe a minute or two on other select high-grade renal cell carcinoma. ALK rearranged RCC have ALK gene rearrangements in fusion with diverse genes like VCL, TPM3, EML4, HOOK1, and others, which leads to formation of an oncogenic ALK fusion chimeric protein, which can actually be targeted by specific ALK inhibitor therapies. And these patients with ALK rearranged tumors can show metastases and poor outcome in almost 25 to 30% of these cases. But I think the gratifying point now is that we have these ALK inhibitors, and these tumors can tremendously respond to ALK targeted therapy. We as surgical pathologists, again, cannot miss these diagnostic entities because, interestingly, these tumors will respond only to ALK-targeted therapies. So if these tumors are erroneously diagnosed, they're not going to respond to conventional renal cell carcinoma regimens. These tumors can happen in pediatric or adult patients. The pediatric patients can have a sickle cell trait with this particular VCL ALK-based fusion. And this is one of the more classic looks for this tumor. These tumors can have a reticular look with a mucinous or myxoid background. It almost looks actually like a yolk sac tumor of the yolk sac germ cell tumor. And again, we can see over here there is a mucinous myxoid sieve-like architecture. We have this intracytoplasmic lumina mucin-filled spaces, and we can also see psammomatous calcification. Very important to be careful with TFE3 immunohistochemistry. This can be non-specifically expressed in this tumor. INI1 is retained, and ALK ISC shows strong expression, and confirmatory FISH is highly recommended for these cases. And this is the ALK ISC done on the same tumor. I think, like I mentioned, there are several case series and case reports now that these patients tend to respond to ALK inhibitors, and I think, and hence it's very important for them to be correctly diagnosed. For example, in this nice report in JCO Precision Oncology, it was shown that this ALK rearranged RCC responded very well to ALK inhibitor entrectinib. We have also learned about NF2 alterations recently in renal cell carcinoma. NF2, like you know, codes for Merlin protein, and currently biallelic NF2 loss is implicated in patients who have MTSSC, some RCC with papillary features, sarcomatoid RCC, unclassified RCC, and also this entity known as biphasic hyalinizing psammomatous renal cell carcinoma. Santosh, I still have a few slides, but just let me know when you want me to stop. I think I have probably another 5 minutes, but I defer to you.
Please carry on. Please carry on. No worries.
Okay, thank you. So there is this concept of biphasic hyalinizing psammomatous renal cell carcinoma. Again, NF2 gene is implicated at the biallelic level in these tumors. And these tumors at the microscopic level can have solid areas, tubulopapillary areas, and then these interestingly glomeruloid features. And the background can be very hyalinizing to sclerotic in nature. Here we can see the psammomatous calcs, and we can see a very hyalinizing and psammomatous background, and the tumor is inherently high grade in nature. I came across this renal tumor biopsy actually in the last few months. And when I worked up this tumor, it was again positive for loss of Merlin ISC expression. We have to remember that Merlin loss can happen both in a primary and secondary fashion in these tumors. Recently, we have written this review article. I think this is in the journal Kidney Cancer, so please visit this when you can, and I hope you will find it helpful. This is a renal cell carcinoma with eosinophilic features, high degree of nuclear anaplasia, and when I worked up this tumor, it was only positive for pancytokeratin, PAX8, and PAX2. And at the molecular level, we did not find a distinct genomic underpinning. So this is an example of a renal cell carcinoma not otherwise specified or unclassified. And what we have learned from Dr. Jingbei Chen's work at MSKCC is that when renal tumors are correctly placed in the RCC NOS or unclassified category, actually these tumors tend to group together and they are enriched for aberrations in the NF2 or mTOR TSC pathway aberration. So I think it is important to remember to place renal tumors correctly, even within the unclassified or NOS space, because there can be distinct management implications for these high-grade carcinomas. This is my approach towards difficult to classify renal tumors. I think morphology is the key. I think firstly, it's very important to rule out uncommon morphologic patterns of common RCC. I think then it's important to rule out well-established but uncommon RCC and then utilize molecular assays as needed. I'll skip this. I've talked already about this. And this is my current approach towards difficult to classify renal tumors. When I have a challenging renal tumor, this is my first tier workup always, followed by biomarkers I have within the second tier workup. And then I resort to molecular testing or resort molecular testing when there is a difficult to classify tumor, especially when it is advanced, locally advanced in nature, or it already has a metastatic phenotype, or there is a germline hereditary annotation. And these are specifically the instances I highly recommend molecular testing, which could include FISH, RNA, or clinical next generation sequencing. And I think these are the different clinical assays, molecular assays available, which includes FISH assays as well as next generation sequencing based technologies. So this is the last segment of my talk. I'll spend just a few minutes on emerging concepts and new directions. The concept of whole chromosomal copy number variations is now well established. This is cutting edge, but well established in kidney cancer. And we, as well as others, especially Dr. Sona Gupta from Mayo Clinic, has shown that different renal cell carcinoma subtypes show distinct CNV patterns. And actually, these are amenable to clinical assay development. And this in this very nice article by Dr. Gupta and colleagues from Mayo Clinic, they have shown that how CNV patterns can help in distinguishing different renal tumor subtypes. For example, this is a clear cell RCC versus clear cell papillary renal cell carcinoma. And we can see over here that this tumor shows the signature 3P loss, which can be very helpful in these instances. So please review this study for other examples as well. So the CNV assays now carry diagnostic, prognostic, as well as hereditary annotations. I'm a bit running out of time, but I highly recommend visiting this review article for gaining more insight into these utilitarian patterns for patients with RCC.
You can take as much time. No
okay.
problem.
Okay, thank you. Like other fields of life and science and medicine, artificial intelligence has also made an intent into the kidney cancer world, actually way more on the therapeutic side, which sometimes we don't get a direct glimpse of, but I'm involved in some therapeutic studies, and I think AI is making a huge intent there. But today I will share this study, which Dr. Liang Cheng invited me to participate on, where we were able to distinguish between clear cell renal cell carcinomas and TFE3 rearranged renal cell carcinomas using an AI-based algorithm which was developed. And this AI algorithm was so powerful that all we needed were H&E images and this AI algorithm without any molecular testing to faithfully distinguish between these two different renal cell carcinoma subtypes, which were the high-grade RCC and the TFE3 rearranged RCC. So please visit this remarkable study when you can. And in this study by my clinical colleagues at University of Michigan, also similar AI-based algorithms have now been utilized to distinguish between different renal cell carcinoma subtypes. So these are some leading questions. I think the residents, fellows, and trainees on this meeting call, I'm hoping they can gain. I'm hoping they can pick up some of these topics, and all of us can learn from ensuing work, which includes how to correlate molecular subtypes with therapeutic opportunities. What are the predictive markers of treatment responses? How can we design and enroll molecularly informed clinical trials for patients with RCC? What are the cell of origin related opportunities, and how does this intersect with the interplay of genomic, epigenetic, and microenvironment based features for renal cell carcinomas? I believe this is my last or second last slide. I think for me, the overarching goals around renal tumors include delineation of cell of origin, what are the distinct histopathological and clinical features, what are the different biomarkers within the space, what are the genomic, epigenetic, expression signature, metabolomic, and copy number patterns for different renal tumor subtypes, and how can we accrue all this information to help our clinical colleagues perform better molecularly informed clinical trials and help guide their management strategies. to deliver better outcome goals for our renal cell carcinoma patients. I think I showed a lot of work, and I think a lot of this work has been done in collaboration with my colleagues, collaborators at a lot of different institutions all across the world. I think I'm thankful to my family. I think actually some of my family are also interestingly, my collaborators. And then obviously, I think a big thanks to Dr. Mohanty, I think, who has always been a visionary, a phenomenal mentor. I know how Sambit liked to teach. And I think Sambit has obviously left a legacy behind. I'm personally thankful to Dr. Manti for his vision, his unconditional collaborations, his leadership, his amazing legacy. I think Sambit's passion and dedication to geo-oncology will continue to live on through his deeply insightful and amazing contributions he has made. Thank you again to all of you for listening to this talk. I know it is late in Asia, and I know there are people from all over the world on this call, but thanks to everyone for your attention. Thanks again to Anandi, Santosh, Sanjay, and the MEU India team, and I'm happy to take any questions.
Thank you, Dr. Mehra, for that very insightful and in-depth talk about renal cancers, especially the molecular aspects, the CNV, and how you have an algorithmic approach, the first markers which you put, and the second, and how you're going to work up with this molecular sequencing in these tumors. We have few questions in the chat box. I'll start with the questions which are in the chat box. The first question is by Dr. Srinivas. Is there any molecular pathology difference between metastatic RCC and the non-metastatic one, is it? Yeah, I think so. Let me just check.
That is a good question. I think that's a great question by Dr. Srinivas. The majority of the work which has been done by TCGA and CPTech has been on the primary renal tumor samples. A lot of our work also has been done on the primary tumor samples. That's interesting. Dr. Srinivas is asking because currently we are working on a study which is highly enriched for metastatic renal cell carcinoma patients. There are significant differences in terms of intra-tumor heterogeneity, which becomes very profound at the metastatic levels. I think the CNV patterns get affected. BAP1 loss will be enriched for patients who have metastatic renal tumors. And there are other biomarkers also like IGF-2BP3, which will enrich in a metastatic tumor phenotype. I think this question is very insightful because what we have seen is that even in between different metastatic tumors, there can be genomic differences. For example, there are metastatic tumors which will have BAP1 loss, and there are metastatic tumors which will have BAP1 retained. And what we have seen is that even at the metastatic level, when patients who have renal tumors with BAP1 loss, they tend to do worse than those patients with retained BAP1.
Yeah, another question from Dr. Padmaja is that do you do an algorithmic approach with IHC in molecular and RCC cases, or do you do them simultaneously?
I think that's a good question, a very practical question. So I mean, I think I can tell what is recommended or what I would recommend because I think this is the approach I generally tend to follow. So I mean, there is a clear-cut distinction in between these. Like majority of cases, we are able to resolve with this first-tier markers. But I think I'm in a very tertiary and quaternary practice setting, and I think we definitely have tumors where I have to work up, where we have to use this marker. I also use TRIM63 frequently because negative TRIM63 rules out a possibility of MITF RCC like practically. So far, I have not seen a tumor which was MITF RCC at the structural or genomic level and which was TRIM63 negative. But there are cases which we will not be able to resolve. And then that is when we go to CNV testing or clinical next generation sequencing based testing. So generally, this is a tiered approach. I will not generally do this at the same time. And we do resort or keep this at a reserved level. Also, for these cases, especially the next generation sequencing, I always do it in conjunction with a clinical colleague, like who is the medical oncologist on the case, as well as who is the who's the
cost up.
urologic oncologist on the case.
It does
Yes.
drive the cost up. I think the
Exactly,
RNA-ish,
exactly.
TIM-ish would also be a pretty expensive test.
So that's a good question, Santosh. Actually, in practical laboratories now, RNA-ish cost is equating now or coming
Right.
relatively close to IHC.
Yeah.
So the same Ventana machines and the same Leica machines, like Leica Bond, they can do RNA-ish. And RNA-ish probes are actually available commercially and clinically.
Yes. I think they're
And
used pretty rampantly for HPV testing RNA-ish, and I think
exactly,
the same
exactly. You're absolutely right.
platform can be used for TRIM IHC testing.
Is the same for TRIM63. Actually, I did not list another probe, 1187. That is also we use for oncocytic renal tumors. It's an intercalated cell marker. So actually, we utilize, and I know other laboratories too utilize RNA-ish like just as IHC. I understand there's a little bit learning curve involved, but this is not rocket science. If anyone can do IHC, they can easily do RNA-ish. But that was a good question.
Yeah. So Anandi asks that has molecular defined renal cancers genuinely reduced the unclassified RCC category?
I think obviously great question, man, Nandi. Uh, Intuitively speaking,
Yes,
yes.
I think so. Yes.
Intuitively speaking, yes. But I think that's an important point Anandi has made. I would still like to see a categorical study on how molecularly defined RCC or use of genomic analysis will reduce the number of unclassified tumors. But intuitively, I think that would be a positive study if anyone would do that.
There are no more questions. A couple of questions, if I am allowed to ask.
Yes, absolutely.
Dr. Mehra, with your experience, do you think that there would be a category of mTOR TSCs separated out as a molecular defined, maybe with different morphologies, of course?
Yeah,
Is
no,
there
no.
a
I think that,
possibility, because there are so many tumors in the mTOR TSC1, TSC2 category? In fact, it keeps on increasing day by day. This category of tumors.
yeah, no. I think that is very. I think that's a very important question. I think Santosh. So we actually, in collaboration with Dr. Rajal Shah, I recently wrote a review article on mTOR TSC RCC, and I've also done with Dr. Pete Argani. My personal concept around this is that mTOR TSC family of renal tumors is a distinct, unique subset of cases. I think we should be and we need to separate them out from other renal tumors. That will solve a lot of current classification problems. Having said that, uncommonly in less than 5% of mTOR TSC, in less than 5% of other RCCs like clear cell RCC or chromophobe RCC, mTOR TSC pathway involvement can happen, but that is not a new phenomena in the renal tumor world. Because we know of other tumor subtypes where there can be a crosstalk in between different pathways. So I think, but the fact that we have learned so much, about mTOR TSC pathway renal tumors, I do feel they befit their own category because their biomarker profile is distinct. Their morphologic markers are distinct. They have underlying mTOR, TSC1, TSC2, or Reb gene aberrations. Having said that, within the mTOR TSC pathway space, based on principal component analysis, we have also seen that these tumors are still distinct entities. So I believe these are discrete genomic and metabolomic inserts which are contributing to these tumors. Another point which I should have probably mentioned in my talk as well is that I think it is important to also look at the mitochondrial and metabolomic status, at the mitochondrial dysfunction and metabolomic status of each of these renal tumors, especially the eosinophilic ones. It's very interesting because we will see normal mitochondria in several different renal tumor subtypes. For example, eosinophilic vacuolated tumor and renal oncocytoma almost have normal looking mitochondria at the EM level. What happens at the mitochondrial genomic level and the mitochondrial functional level is a different story. But I think there is more work which needs to be done in that space.
Yeah, I think that exemplifies that RCC in general is a metabolic disease, and it does have a lot of metabolic
Yes,
pathways which
yes,
are active.
absolutely. That's absolutely correct.
One question which is probably a little beyond the purview of this is a bit many people would have in the audience is that when we grade RCCs, we take sarcomatoid as rhabdoid as grade 4. Do you include any other thing as grade 4, say multinucleation, or well, is there anything which makes you feel it is more grade 4 if it is not sarcomatoid or rhabdoid, but it is grade 4?
Well, we obviously have our ISUB WHO grading system, which talks about true tumor anaplasia.
Yeah.
And I think that is an important, at least currently, that is what the field is pointing towards. That is what is grade 4.
Yeah.
I mean, currently, chromophobe RCC grading is not incorporated
Not
into.
in chromophobe. Not in chromophobe.
Currently, it is not incorporated. But having said that, there are distinctly chromophobe RCC with atypical features, and these tumors tend to be higher of higher cellularity with more mitotic activity, and has true nuclear atypia. So, I mean, I think these are also higher grade chromophobe RCC. I think a lot of this work has been done by Dr. John Shavil at Mayo and Payal Kapoor at UT Southwestern. And what they've also shown is that there are underlying genomic aberrations also, like P53 and RB pathway aberrations. So I think, I think Santosh, what you're asking is really very important and insightful, because I think grade is applicable only to certain renal tumors.
Yes.
And I think grade is used loosely for tumors where there is currently no evidence in literature for. So I think it's important to stick to grading currently for clear cell RCC and papillary renal cell carcinoma. Grade might be applicable for some other tumors. It might be helpful, but I think more work needs to be done in that space. So I think grade helps quite a bit, but most commonly in these tumor categories we mentioned.
And maybe one last question. In a renal cancer which is organ confined, say a T1A tumor or T1B tumor, would you make it a point to write down the percentage necrosis in those tumors? And does it have implications? Do your clinician really want that to be put in the report? I know the CAP does, obviously, CAP guidelines do put it, but does it carry a huge
I think no, I think again this is an important question. I think necrosis, does it matter? I think definitely. I think definitely necrosis is important. I personally generally say necrosis identified or not, and I think I don't know if clearly data exists. Mayo Clinic has done the maximum amount of tumoral necrosis. Actually, the reason necrosis exists in our CAP templates is because of the work done by Mayo Clinic, which has shown that necrosis matters at the multivariate level.
Yeah.
I personally don't tend to distinguish between that. Having said that, if I see a globally necrotic tumor, which is like more than 70% or more than 80%, I will probably say in a comment that this tumor shows profound necrosis.
Okay.
So I think I do not quantify it, but yes, in the higher percentage states, perhaps more than 50% or 60%, I might put in a comment.
Okay, fine. I think there are no more questions in the chat box. Just one question has popped up. Let me check. I think Dr. Rajan Arora has put up and saying thanks. So most of the comments in the chat box are thanking you and for your presentation and insightful talk, Dr. Mehra.
Thanks to everyone for being here. And I know it's late time, probably dinner time for a lot of people. So thank you for.
Anand, if there are no
questions. Doesn't matter, but we are very grateful.
Yes.
देर आए दुरुस्त आए, पर इतनी superlative talk हमारे platform पे, I mean it's amazing.
Yes.
Okay,
yes.
Thank you, Dr. Bill.
Yeah. So Anandi, can we close the meeting?
Yes. Thank you very much, Dr. Mehra. Thank you, Dr. Menon. It's a lovely lecture.
Thank you, Anandi.
Okay. Thank you.
Thank you, everyone. Thank you.
I'm closing the session.
Yeah. Thank you, sir. Thank you so much.